covering anatomy of the ear and pathologies of the ear. So, as far as anatomy of the ear, I assume that you've had this with Dr. G in your upper extremity class. So, just briefly, what we're going to be talking about is the outer ear, the middle ear, and then the inner ear. Okay, so outer ear, middle ear, and inner ear. You'll notice on this next slide that they're broken down into individual components. So you'll see the pinna, cartilage, external auditory canal, all the way down to the lateral surface of the tympanic membrane on that outer ear. So what we're talking about here is this outer portion of the ear, all the way through this auditory canal to the lateral portion of the tympanic membrane. Once we hit that lateral portion of the tympanic membrane, we're going to transition into the middle ear, which you'll notice right here. So the middle ear consists of this medial tympanic membrane and then the malleus, incus, and stapes, so the three conductive bones that are going to transmit sounds here into the inner ear. So I come down here, middle ear, medial surface of the tympanic membrane into the ossicles, the malleus, the incus, and the stapes, which transmit the sound. You'll also notice connected to the nasopharynx by the eustachian tube. So if I come back here, this is that eustachian tube right here that connects the throat to the ears and allows for equalization of pressure there. So then finally, the inner ear is going to contain the vestibule, the semicircular canals, and the cochlea. So these structures are particularly responsible for changing the mechanical signals that are transmitted via conductive sounds, so these vibrations, to electrical signals. So you'll notice when we look at this picture, we're going to have these nerves coming into this cochlea, this semicircular canals, and vestibule. Thank you. So the vestibule, the cochlea, and the semicircular canals right in here. So you'll see this nerve, and this is cranial nerve number 8. Cranial nerve number 8. As it comes down, and this is where those mechanical signals are transmitted to electrical signals. Okay, so just a little bit more on this inner ear. So the vestibule is responsible for balance as the fluid in the semicircular canal shifts with head movement. So as our head moves, you'll notice that these canals are oriented into 3 different planes and 3 different directions, right? So transverse, we have one more upright, and then we have this one. So as we move, we have little tiny hairs inside of each of these, and the fluid passes over those. And as the fluid passes over those, it's one way that we receive balance. The cochlea is going to transmit those mechanical vibrations to electrical impulses and sent via cranial nerve number 8, vestibulocochlear, named for the structures that it comes to meet. Okay, and then finally, those semicircular canals off of the vestibule house the fluid that shifts those messages for balance. Okay, so when we perform an examination of the ear, we're looking for size, shape, symmetry, right? Obviously, any gross deformities or cuts. The ears, because they stick out, they can receive some unique injuries. So one thing that the book gets into a little bit is this Weber and Rene test. So I think this is Rene, I think is a French person, so Weber and Rene. So we'll talk about those briefly in class tomorrow with some more depth, but I'll try to address them a little bit here. And then we're going to look at this the external ear into that middle ear where we're going to see that tympanic membrane using the otoscope. Okay, so if we see pink, red, and bulging, we're going to have inflammation there in that middle ear. Bluish, dark color is going to be blood. White color is going to be pus. And then perforations is going to indicate a ruptured tympanic membrane. Okay, so just a few things there. So as far as this Weber and Rene test, so hearing loss. Hearing loss can be due to conduction, so the sound waves, right? So if you think about it, sound is a vibration, and as that vibration goes into our auditory canal, it hits the tympanic membrane, and that tympanic membrane, let me come back up here, that tympanic membrane is going to vibrate. You'll notice that this malleus is connected to that tympanic membrane, so this vibrates. It vibrates the malleus, the incus, and then the stapes, and that vibration comes into the vestibule, and then those vibrations are transmitted into the cochlea and then return to the brain as electrical signals, which tell us that there's sound. So we can have problems with hearing here at the middle ear, where maybe this vibration is not conducting right down the chain. We can also have sensory motor problems here at the inner ear in the vestibule and the cochlea. Okay, so if I come back here, we can have air conduction problems, but we could also have sensory neuro problems if those vibrations are not understood. Maybe we have a nerve problem, or we're having a problem where those vibrations are converted. So we can have it sensory motor or sensory neural, sensory neural, or we could have it conductive. Okay, so the Rene and the Weber test help us differentiate if we are having sensory neural problems or if we're having conductive problems. So on this Rene test, I actually have a video of this that I was pulling up. So on this, here we go. On this Rene test,
the Rene test enables unilateral comparison. Sound conduction is more efficient via air than via bone. Place a vibrating tuning fork against the mastoid bone. Sound waves now travel to the inner ear via bone conduction. As soon as the patient can no longer hear the sound, hold the tuning fork next to the patient's ear. The sound waves are now conducted via the air. Patients with conductive hearing loss are no longer able to hear this sound since air conduction is severely impaired.
Okay, and I'll pause that there. So what we'll do here on this Rene test is we're going to use the tuning fork. We'll hold it onto a bony part of the ear. They say the mastoid. You could actually probably hold it above or below any of these bony prominences that are going to lead us here. So the sound of the tuning fork should always last longer than the bone conduction. So if we hold the tuning fork on the skull, and then the patient says, okay, I can't hear that, and then you hold it next to their ear and they can't hear it, then we begin to assume that they have a conduction problem. Okay, so then let me fast forward here.
Start by placing a vibrating tuning fork medially on the patient's head. The sound is now transmitted via bone conduction. Physiologically, it should be heard centrally, or, in other words, equally loud in both ears. Unfortunately, the patient reports the same finding in both bilateral conductive and bilateral sensorineural hearing loss. This can be the cause of falsely diagnosing a patient as healthy. If the sound is heard louder on one side, this is called lateralization. It can have two different causes. In the case of unilateral sensorineural hearing loss, sound lateralizes to the unaffected side. For example, in right-sided inner ear damage, the sound is louder on the left side. If unilateral conductive hearing loss is present, sound lateralizes to the affected side, since, as mentioned before, bone conduction results in a sound that is perceived as louder.
Okay, and I'll pause that there. So that's the Weber test, where you'll use the tuning fork, you'll hold it over, you'll contact the head at the top. It should be heard by both, and it should be centralized. If we localize to one side or the other, that's going to indicate hearing loss. So again, if it's louder on one side, then we assume that's the inner ear trying to compensate for this lack of conduction. Or it could also mean that this other side has inner ear problems. So we have to differentiate a little bit. But that's examples of the Weber and the Rene test. And so you'll see this here. So on normal, air conduction time should last longer than bone conduction. So if a person is unable to hear after the bone conduction goes away, then we suspect that they have conductive hearing loss. If they have sensory neural problems, the air conduction will be heard longer than bone, but it won't be 2 times as long. So anyway, just a little bit on that there on that Weber and Rene test. We'll practice those. So here's Weber and Rene. Okay, and then we'll get into just a few of these pathologies of the ear. So in general, we can have some hearing loss. So sometimes we have hearing loss that's transient, right? And sometimes it's longer. So diagnostics, we're going to use Rene's and Weber's. You can also refer to an audiologist who's going to have some sophisticated mechanisms to determine hearing loss. So, and then return to play based on the cause of the loss. So hopefully we're using ear protection where we need to resolve that. Otitis externa, so we look at this, inflammation, right? Inflammation of the external ear. So inflammation or infection of the external auditory canal or eardrum. This is often also called swimmer's ear. It's called swimmer's ear because sometimes water gets trapped in the auditory canal of the ear, and that allows for bacterial growth. So if we have bacterial growth, then we get inflammation, which is going to create some hearing problems, right? So common in swimmers because the water allows for buildup. But it's interesting because chlorine's probably not going to be in that same. Anyway, it gets kind of interesting why it's called swimmer's ear, but that's the history of it. And this is what that's going to look like. So using an otoscope, you're going to try to peer in and you're going to notice red inflammation problems before you can even visualize that tympanic membrane. Okay, so that's otitis externa, swimmer's ear. So pain, pressure, people are going to tug at the ear. So treatment, it's a bacterial infection. It's a bacterial infection. So sometimes we're going to use eardrops. Maybe some type of a drying agent. It may become progressive and you may have to use some type of an antibiotic, either external or internal. It just depends a little bit. Okay. On the flip side, we're going to have otitis media, so inflammation of the middle ear. Inflammation or fluid in the middle ear. Super common in kids, so common in kids. Due to various reasons. It's going to hurt. People are going to complain that they can't really hear that well. They may actually end up having some balance problem. It usually comes on quickly with some hearing loss. Treatment is very simple. It's antibiotics. So this could be, most of the time in kids, they'll get some type of a pus going on inside of their ear. It could be viral or bacterial. Most of the time you'll go to the doctor and the doctor will just will write a prescription and dispense antibiotics. In the event that it is bacterial, hopefully that can go away quick. This an ear infection is the colloquial term for this. An ear infection is debilitating. It hurts. It's hard to sleep. It's hard to do anything. So a lot of times the doctor will just prescribe antibiotics right away to try to get those going. So once symptoms are controlled, that individual can definitely return. But you just have to be thoughtful because if there's still a bulge, if there's still a lot of pus, then potentially that tympanic membrane is under pressure and can rupture a little bit easier. Okay. So here's what that looks like. So we're going to see this bulging red, pink, with this pus that's building up in the middle ear. Okay. So finally, we can have a ruptured tympanic membrane. It can either be fairly small or fairly large. I've known a couple people that have developed a ruptured tympanic membrane following diving too deep. So anyway, that's kind of interesting. Sudden change of pressure, like in diving, blunt trauma, if you stick something in your ear, or if you have that middle ear infection and then take a blow or whatever, you could rupture that tympanic membrane. So signs and symptoms, whistling, decreased hearing, sometimes fluid or bleeding from the ear for sure. And then they may also have some balance stuff going on with some vertigo. Okay, so as soon as that otoscope goes in and you see that, though, it's a pretty quick diagnosis and assessment. So treatment, heal on its own, it'll just take some time. So you just want to control for pain. drying agents if needed, and then if you're worried about infection, obviously you can do some antibiotics. And then if it's small, hopefully they'll return pretty quick. If it's large, it may take a little bit longer. If it's an underwater sport, it may take longer because they have the rupture, right? So, okay, that finishes this video on the ear.